Medical specialists, we asked ourselves, how can we most effectively support the work, ambition, and dedication of these individuals? We sought out dialogue. We listened, and we understood. With a supportive exchange among medical professionals who network their knowledge around the globe, so that they maintain their expertise at the highest level for their entire lives. With disciplinary approaches that promote specialization without losing the perspective on medicine as a whole. With smart, modular concepts that are compatible with the busy lives of medical practitioners and nurses. With offerings whose contents provide answers for the reality of everyday medical life. With a growing perspective on trends that enables medical practitioners to already prepare for future challenges today. In close dialogue with renowned specialist companies that bear testimony to the quality of the offers. With inspiring forms of learning that don't just convey knowledge, but make it an experience for the senses. And with innovative teaching methods that prepare you not just for tests, but for life. Nurses and care assistants, physicians and hospital managers, and the people who work in the home healthcare services sector. All of those who teach and learn at the Escolap Academy share a passion for excellent medicine and very high personal standards. We invite you to join in a dialogue about health and medical care. A dialogue that is dedicated to life.
Sharing knowledge, learning something new, gaining confidence, thinking medicine, improving health. This is what drives people at Escolap Academies all around the world. And this is why we communicate with one another in a dialogue that is dedicated to life.
All around the world, both speakers and participants, as well as researchers and practitioners, meet at Escolap Academies in order to think medicine further ahead. Is there anything more valuable than a dialogue dedicated to life?
The Escolap Academy connects people who want to know more, to improve medical care. They are looking for a dialogue. We offer a dialogue dedicated to life.
Dialogue dedicated to life.
对话致力于生命健康。
Diálogo dedicado a la vida.
Dialog посвященный жизни.
Dialog dedikasi bagi kehidupan.
Dialog dedykowany życiu.
Dialogue dedicated to life.
الحوار مكرسة للحياة.
Diálogo dedicado à vida.
Dialog pro život.
Become part of this international, interdisciplinary dialogue at Escolap Academies all around the world. A dialogue dedicated to life.
Good morning, good afternoon, and good evening, everybody. I would like to welcome everybody to Escolap Academy Digital Dialogue hemodialysis webinar. We will be discussing infection control, prevent the preventable. In the era of COVID-19, now we understand the importance of infection control, and I guess these topics are really topical and right on time. My name is Dr. Abdul Halim. With us, we have the speaker, Dr. Rosnawati. She is my good friend. She is a consultant nephrologist from Hospital Kuala Lumpur, Malaysia. She is for the last 17 years and completed her fellowship in the UK. She is currently the president of Malaysia Society of Transplantation and also president of Postgraduate Renal Society of Malaysia. Dr. Rosnawati is actively involved in research. This is the agenda for today. Dr. Rosna will speak about 60 minutes on infection control, prevent the preventable. And I just would like to inform everybody there will be poll in the presentation, the talk itself. So I hope that everybody will contribute and answer the question in the polls. And finally, at the end of this webinar, there will be question and answer. I hope everybody will actually join and ask question in the question and answer session. This is some important messages. One is that make sure that note that your microphone is muted throughout the session. Please post your questions. We want more questions. We need a lot of questions in the question and answer section, not the chat box, but question and answer section anytime throughout the session. This session will be recorded. At the end of the session, there will be link and passcode to generate e-certificate that will be shared. For Malaysian doctor, at the end of the session, we will actually put a QR code where you need the MMA apps to actually get and also scan the QR code. With that, I will pass the floor to Dr. Rosnawati Yahya. She will speak on infection control, prevent the preventable.
Okay. A very good evening, ladies and gentlemen. Thank you, Professor Halim, for the kind introduction. Thank you to all the attendees for taking the time of your busy schedule to attend these webinars. And finally, thank you to Aesculap Academy for organizing this webinar and the invitation to speak. This is the content of this presentation. I will go through a short introduction to infection control in dialysis. I will speak on infection control practices, particularly focusing on recommendation made by CDC or Center of Disease Control. After that, I will touch a little bit on immunization in dialysis, staff education and competency, the importance of patient education and family or caretaker engagement, strategies to improve adherence in care delivery, and a summary at the end. In between, as Prof. Halim mentioned, there will be a poll, questions, and we would appreciate participation from all. Okay, as you know that patients with end-stage renal disease treated with hemodialysis are at substantially increased risk of life-threatening infections. Infection result in significant morbidity and are second only to cardiovascular diseases as the cause of mortality in patients with end-stage renal disease. Majority of bloodstream infection are related to vascular access, of which 70% are associated with the use of a dialysis catheter. In addition to bacterial infection, patients on hemodialysis are also susceptible to viral infections, including hepatitis B, hepatitis C, HIV, and in the current pandemic, also to COVID-19. Outbreak of HCV infection in hemodialysis facility continue to occur due to poor infection control practices. We also see many infections due to multi-resistant organism, with MRSA being one of the leading cause of catheter-related bloodstream infection, and other multi-resistant organism including VRE or vancomycin-resistant enterococci, NESBL producing organism. Another important infection in dialysis are respiratory infection, which include COVID-19, tuberculosis, influenza, and pneumonia.
Now we take some poll. I hope people can answer, what is the percentage of patients using central venous catheter in your dialysis unit? We give about maybe another 20 seconds. people are still answering. That's very good. There's a lot of answers coming in. Okay, let us look at the results now. So you see that majority of the participants said that is about 1 to 10% of their patients are using central venous catheter in their dialysis unit. I think in Malaysia, right, Dr. Rosna, the last figure was about 14% of Malaysians, the dialysis patients are using central venous catheter.
I think that figures is still around that, but perhaps increasing in the last 4 years or so.
Yeah.
The last data we have for Malaysia is about in 2016, right?
Yes, 2016. Okay.
Yeah.
Okay. Thank you.
Okay, so we can see that there are a lot of patients are actually on catheters for a population of dialysis patient, which is about 42,000 dialysis population in Malaysia. We are talking about 8,000 people are actually on catheter, roughly about 8,000 patients on catheter, right? So big numbers. Okay, so moving on, the next item that I want to go through is how does actually infection get transmitted in dialysis facilities? Of course, first is through contact transmission. In dialysis, infection is commonly spread by contact transmission and most commonly by contaminated hands. So yours and mine. Second mode of transmission is through droplets or airborne transmission. Of course, in the pandemic of COVID-19, this become most important transmission of infection in dialysis unit as COVID-19 are known to transmit it through droplets. And the same goes for influenza, whereas tuberculosis is spread by airborne. And other sources of infection in dialysis unit include contaminated device, contaminated equipment and supplies, contaminated environmental surfaces, from dialysis personnel where bacteremia can occur during connection for dialysis, through contaminated items such as glove or infused solution, and if the staff is chronic staphylococcus, Staph aureus nasal carrier, they can transmit this to the patient and can also occur from patient to patient. I'm going to spend majority of this lecture on the infection control practices recommended in all dialysis facilities. And we know that lapses in infection control practices such as hand hygiene and the environmental cleaning have been associated with bloodstream infections and hepatitis C outbreak. And dialysis personnel need to be thoroughly trained in standard precaution designed for all outpatient healthcare facilities, as well as specific recommendation for hemodialysis unit.
So another question, we will take a poll now. There's no right or wrong, but we just want to see how many, So do your dialysis unit have a written standard operating procedure on infection control? Oh, still answering, that's really good. We give another 10 seconds for people to answer. Okay, let us look at the result. So majority say yes, 90% say yes. We have a documented standard operating procedure on infection in the dialysis unit. And this is necessary and majority, right, Dr. Rosna?
Yes, and this is very encouraging indeed. Very encouraging to see that majority of dialysis unit actually have policy and procedure on infection control. I'm very happy to see that.
That's great. I think we can stop the lecture now. I'm just joking. Okay. All right.
Okay, This is the recommendation by Center of Disease Control. They strongly recommend several infection control procedures, and these include, number 1, practice of hand hygiene. Number 2, appropriate use of personal protective equipment. Number 3, on safe injection practices. Number 4, cleaning and disinfection of environmental surfaces. Number 5, disinfection and sterilization of medical device and equipment. Number 6, on respiratory hygiene and cough etiquette. And this is the specific infection control recommendation for outpatient hemodialysis facilities, and this include wear glove and other personal protective equipment or PPE for all patient care, separate clean areas from contaminated areas, use of medication vials safely, focusing specifically on medication preparation and distribution of medications, promote vascular access safety, prevent catheter-related bloodstream infection, clean and disinfect the dialysis station between patients, ensure safe handling of dialyzers, and the last one, immunization for vaccine preventable disease.
We have another question here. So, how many times do you perform hand hygiene per dialysis session per patient? Answers are coming in. Maybe we give another 10 seconds. Okay, let us look at the results. And majority actually will perform about 11 to 20 times per patient per dialysis session. So is it acceptable, Dr. Rosna?
I guess it depends on whether the patient develop any complications during dialysis. So usually you have to touch the patient, you have to touch the patient's surrounding if they develop intradialytic complications, right? Otherwise, I think that's pretty reasonable. Yeah.
That's great. Thank you.
Okay. Okay, let's move on. Okay, regarding hand hygiene, you need to be very diligent in the practice of 5 moments of hand hygiene before patient contact. For example, after taking patient's vital sign, weighing the patients, after examining a patient. I think generally our staff is pretty good in this. Before undertaking an aseptic task or procedure, for example, when taking blood, when changing dressing of catheter, when inserting venous access, after exposure to body fluids such as blood, urine, saliva, feces, and vomiters, after a patient contact, for example, after giving an injection, collecting specimen, assist with a procedure, or after changing a dressing and after fistula cannulation. And the last one is after contact with patient surrounding. Generally, in a hospital-based clinical audit, what we find very deficient is actually in item number 5. And generally, staff and even doctors tend to forget to perform hand hygiene after contact with patients surrounding. So I'm just trying to highlight where are the lapses that tend to happen during while performing hand hygiene. So all dialysis facilities need to give a special attention on the adherence to 5 moments of hand hygiene, and this procedure need to be audited at least monthly. And also attention is also needed in adherence to the 7 steps of hand hygiene, and this procedure should be audited for all team members in the dialysis unit. We perform hand hygiene, but whether we do it correctly is another story. So these particular steps is very important, and all staff must adhere to the 7 steps of hand washing with hands if they are using hand sanitizers. Okay, next is on the usage of personal protective equipment. You need to wear disposable glove whenever you care for the patients or touching equipment at the dialysis station. Wear glove when cleaning environmental surfaces and medical equipment. Remember to remove glove and perform hand hygiene between each patient or station if moving from a contaminated to a clean area of the same patients. And this is another area frequently picked up during a clinical audit where staff actually forgot to remove glove in between patients. They use the same glove for different patients. So this is not a recommended infection control practices. In addition to glove, wear gowns and face protection to protect self as needed, for example, during initiation and termination of dialysis due to possibility of blood splashes. So this is more to protect the staff rather than the patient. When cleaning dialyzers, when handling lab samples, and PPE needs to be changed should it become dirty. So this is another poll coming up, Prof. Halim.
That's true. Can you store medical supply in dialysis station, example, under the bed? Yes, is it okay? Yes, if the supply are sealed in boxes, not acceptable. Maybe we give another 10 seconds and we stop. Okay, let us look at the results. Yeah, not acceptable 78. The answer is actually not acceptable. And but there are participants say it is okay if it's sealed in the boxes. But it is not acceptable, right, Dr. Rosna?
Yeah, by right, it should not acceptable because clean medical supplies are actually clean item, and dialysis stations are considered contaminated areas, so it is not acceptable.
Okay.
Okay, we will move on. Okay. The next section will be on clean areas from contaminated, separate clean areas from contaminated areas. All dialysis unit must have a separate clean areas and dirty or contaminated areas. Clean areas should be clearly designated for the preparation, handling, storage of medication, and also storage of unused supplies and equipment. Contaminated area is where used supplies and equipments are handled. Do not handle and store medications or clean supplies in the same or an adjacent area to where used equipment or blood samples are handled. And one thing we must remember that treatment stations are contaminated areas. And items taken into the dialysis station should either be disposed of or dedicated for use only on a single patient, for that patient that you designed the items to be used for, or you can clean it, disinfect it, and before use it on another patient, or taken it back into a clean area. Non-disposable item that cannot be cleaned and disinfected, such as adhesive tape, clothes cover, BP cuff, should be used only on a single patient. Dialysis staff must clean and disinfect the dialysis station between patients. All equipment and surfaces are considered to be contaminated after a dialysis session and therefore must be disinfected. After the patient leaves the station, disinfect the dialysis station. This includes chairs, trays, countertops, and machine after each patient treatment. You must wipe all surfaces. Surfaces should be wet with disinfectant and allowed to air dry. And give special attention to cleaning control panels because these are the area that frequently touched by our hands, so can more likely to be contaminated, and other commonly touched surfaces. Empty and disinfect all surfaces of primed waste container. For a blood spill, clean effectively and immediately with intermediate level disinfection, and usually use tuberculoidal disinfectant or a 1 in 1,000 dilution of household bleach. Another poll, Prof. Halim?
Yes, another poll. Can you pour residual medication from 2 or more vials into 1 vials? Yes, no, and depending on remaining volume of the medication. Okay, let us look at the results. Just for a while. Majority say no. I think that is the correct answer. We shouldn't pull the residual medication from 2 and more vials into one vials. So, but there are about 10% answer that depending on the remaining volume of the medication. Yeah.
And 3% answered yes.
Yes. I think depending on the remaining volume of medication because they learn from the vaccine, I guess. I'm just, no, that's different. That's different.
Cut costs.
Yeah. Okay, thank you.
Okay.
The answer is no.
So the answer is no, right? So we'll move on. Sorry. Okay, next is on the use of medication vials. Please take note that single dose vial is for single use only. Single dose vial cannot be punctured more than once and must be used for only one patient. When multiple dose medication vials are used, prepare individual patients' medication in a clean or centralized area away from the treatment area or dialysis stations. This medication must be delivered separately to each patient. Residual medication from 2 or more vials must not be pulled into a single vial. So usually multiple dose medication vials tend to be, I think heparin is multiple dose medication vial, so they shouldn't be pulled into a single vial. Okay. CDC recommend not to carry multiple dose medication vial from patient station to other patient station because this is a potential spread of infection. And do not use common medication carts to deliver medications to patients. Carry medication vials, syringes, alcohol swab, or supplies in pocket. So you do not carry medication vial or any supplies in your pocket. And medication cart has been implicated in the spread of hepatitis C in some of the dialysis unit. If trays are used to deliver medications to individual patients, they must be cleaned in between patients. Unused medication from the multiple dose vial or supplies that has been taken to the patient station should be used only for that patient and should not be returned to a common or clean area or used on another patient. Okay, next section is on safe handling of dialyzers. Before removing or transporting used dialyzers and blood tubing, you must cap the dialyzer port and clamp the tubing. Place all used dialyzers and tubing in leak-proof containers for transport from station to reprocessing or disposal areas. My units tend to put it in a yellow color plastic bag and tie it off before transportation. If dialyzers are reused, do follow published methods such as AAMI standard for reprocessing and clear protocol on how to handle, store, and dispose potentially infectious waste. Next section is on promoting vascular access safety. First is on cannulation procedure, wash the site. And in my experience, this step is frequently not done or performed by the patient. Whenever I have a patient admitted with excess infection, this is always the case, and patient would admit they tend to wash their excess at home prior to coming to the center, and they do not wash their excess site prior to cannulation. So this is a frequent history finding that I gathered if patients come in with a fistula infection. Next, staff needs to perform hand hygiene, put on a new clean pair of gloves, wear proper face protection, including a face shield. Be careful about blood spill to use, so the face shield is predominantly to protect you. Of course, now everybody has to wear face shield because of COVID-19. Apply skin antiseptic and allow it to dry. Always allow the antiseptic to dry, and in clinical audit, this is another frequent finding that the staff does not wait for the antiseptic to dry prior to cannulation. Insert needle using aseptic technique and remove glove and perform hand hygiene. Similar step on decannulation procedure, perform hand hygiene, put on a new clean pair of gloves, wear proper face protection, remove needles using aseptic technique, apply clean gauze, bandage to site, compress the site with clean glove, and remove glove and perform hand hygiene. I think another poll coming, Prof. Halim.
Thank you. The question is, which step is not necessary during decannulation procedure? During decannulation procedure, perform hand hygiene, wear a new pair of gloves, apply aseptic non-touch technique, apply skin antiseptic to the vascular access site. This is during decannulation, yeah.
During decannulation.
We have very good number of participants. We have about 924 participants, so that's really good. Okay, let us look at the results. And I think majority, 59% answer correctly to say apply skin. You shouldn't apply. You don't have to apply skin antiseptic to the vascular access site during decannulation. But there are some say that you don't have to apply aseptic non-touch technique, but you still have to apply an aseptic non-touch technique during decannulation. Yeah. The answer is the last one, apply skin antiseptic to the vascular access site. A majority answered that.
Okay.
Thank you.
Okay, good. Let's move on. Okay, I'm going to move on to catheter-related bloodstream infection. And I think this is a very important topic, at least in Malaysia. I'm not sure what is happening in other countries. But catheter-related bloodstream infection is a major reason for hospital admission in Malaysia. And a few years ago in 2018, a few of us nephrologists in various hospitals in Klang Valley constitute a big proportion of population of Malaysia. We actually conducted a point prevalence study involving 9 hospitals from May till July 2018. And within that 3 months, we had 290 cases and 8 cases of catheter-related bloodstream infection. And the outcome of this patient is pretty bad. Out of these 298 patients, 5% died, 4% had an ICU admission, 4% developed endocarditis, 0.3% had metastatic spinal abscess, and another 1.7% developed other metastatic infections such as brain abscess, so on and so forth. So recognizing this very important and prevalent problem in dialysis, the Center of Disease Control had come up with a set of recommendations known as core intervention for prevention of bloodstream infection in dialysis patients back in 2017. And this core intervention basically is based on the guideline for prevention of intravascular catheter-related infection that was published in 2011, and this guideline was updated in 2017. There are 3 main interventions in the approach of BSI prevention in dialysis. Given that in Malaysia, as I mentioned, CRBSI continue to be the main reason for mortality and hospitalization, I would like to spend some time to go through this recommendation. So these 9 interventions include, number 1, surveillance and feedback, hand hygiene, observation of catheter and vascular access care, staff education and competency, patients education and engagement, catheter reduction, chlorhexidine skin antisepsis, catheter hub disinfection, and antimicrobial ointment for the exit site care. So I will elaborate on this. So under the surveillance, all dialysis centers must monitor the incidence of catheter-related bloodstream infection in their own dialysis facility. All dialysis units must monitor adherence to hand hygiene. Hand hygiene audit should be performed on the 5 moments as well as 7 step, as well as on the appropriateness using hand rub and hand wash. Management of dialysis facility should monitor staff adherence to aseptic technique on the following procedure, such as exit site care, CVC connection, CVC disconnection, and catheter hub care. And this should be part and parcel of the dialysis unit quality assurance and quality improvement program. This is an example of audit checklist for catheter exit site, catheter connection, and catheter disconnection. And this is all accessible from the CDC website. I'm not going to read through the steps, as I'm sure all of you are aware and familiar with it. I just want to highlight some of the key findings by our auditors and trainers when we conducted the zero catheter infection workshop back in 2019. And the most frequent non-adherence is that nursing staff frequently do not give enough time to allow antiseptic to dry prior to connect catheter to blood lines, and the scrubbing of the hub is considered inadequate. Not enough time is given to the scrubbing the hub process. All staff looking after dialysis patient must adhere to this step, and surveillance audit must be performed, and audit finding must be discussed with the staff at your own respective center. And moving on to the fourth intervention, which is on staff education and competency. All staff must be adequately trained on the center policy and procedure on catheter and fistula care, especially the newly joined staff. Staff education needs to be repeated when necessary or minimum annually. So whenever you see there is a spike of catheter-related bloodstream infection or fistula infection, staff education needs to be repeated. All staff must be privileged prior to handling catheters. So you need to teach your newly joined staff and observe their performance on handling catheters as well on handling fistulas. Privilege them before allowing them to function independently. And I think this is sometimes that frequently lacking in dialysis center. Competency assessment need to be performed annually, or if surveillance shows increased incidence of catheter-related bloodstream infection as well as excess infection. Senior or management staff needs to be trained on audit process to ensure adherence to the policy and procedure. Next item is on patient and family education and engagement. Dialysis center need to provide standardized education to all patients on infection prevention topics, and this should include, but not limited to, how to care for vascular access, the importance of hand hygiene and how to perform hand hygiene, the risk related to catheter use. So hopefully they will find a way to create their fistula as early as possible, given the limitation. At least in Malaysia, we have a long waiting time to get a fistula creation in public hospital for various reasons. It's definitely get worse during COVID pandemic because many elective surgeries are cancelled to accommodate COVID-related admission. And also, sometimes when we know that the patient is going to be stuck on catheter, we need to counsel the patients to accept probably PD therapy when they are deemed to have unsuitable vessel for fistula creations. And how to recognize symptoms and signs of infection. In my experience, many patients, they sit at home for a long period of time, even after the onset of fever. They don't correlate that the signs of fever, symptoms and signs of fever or chills is an early signs of infection. And they come to hospital very late in a septic condition requiring ICU admission. So this slide will cover the last three items on the CDC core intervention. First, in exit site care. Okay, on exit site care, the antiseptic of choice is alcohol-based chlorhexidine containing more than 0.5% solution. And this should be the first line skin antiseptic agent for central line insertion as well as during dressing change. However, if your patient has some form of an allergy to chlorhexidine, the alternative would be povidone iodine, which was the antiseptic of choice when I was a trainee, and preferably with alcohol, or use 70% alcohol. The second one is on catheter hub disinfection. Routine performance of catheter hub disinfection or scrub the hub with an appropriate antiseptic after cap is removed and before accessing the central line, and this must be performed every time when catheter is accessed or disconnected. Majority of the dialysis unit that I have been auditing will perform this quite well, except when the patient actually requests to stop the dialysis in between to go to the toilet. Once they come back, when they reconnect the patient, this step is often forgotten or missed. So this is another potential source where bacterial is introduced. Last is on ointment, antimicrobial ointment. Apply antimicrobial ointment or chlorhexidine impregnated dressing to the catheter exit site are essential step in infection prevention. This is to be performed after catheter insertion as well as at each HD session, CBC HD sessions. The ointment that is recommended are povidone iodine ointment, bacitracin, gramecidine, or polymyxin B ointment. Mupirocin can be used, however, there is concern exists about development of antimicrobial resistance and their ability to cover the spectrum of potential pathogens, including gram-negative as well as gram-positive bacteria. I guess mupirocin is pretty good for gram-positive, but the coverage for gram-negative is not as good as the others. Antibiotic lock solution have been shown to lower the rates of infection, but generally are not recommended for prophylaxis due to concern for development of resistant organism. Another
question.
poll coming up, Prof. Halim.
Okay. Which one is not part of CDC core intervention to reduce bloodstream infection? One is monitor incidence of bloodstream infection. B, hand hygiene observation. C, reducing catheter. And D, caregiver education engagement. This is quite a tricky question, really have to read. And these patients they already have a catheter, right? Yeah, they already have a catheter, so how to reduce it? And what is not part of CDC core intervention? Let us look at the results. Majority actually answer reducing catheters, but correct me if I'm wrong, Dr. Rosna, the answer is caregiver education and engagement. It is not part of CDC core intervention, is it?
Correct, I think so. I mean, it's quite tricky,
right?
Yeah. Yeah, but reducing catheter is definitely part and parcel of CDC core intervention. But I think the fourth question, if it would be patient education, would be correct. But this is caregiver education. So patient's education is more important.
Thank
you. Like you said, this is a tricky question.
Very tricky question.
Okay, I'm going to, I'm going to move on. Okay, the final item on standard precaution is actually on respiratory hygiene. This is extremely important when we are facing the COVID-19 pandemic. Dialysis center must implement measures to contain respiratory secretion in patients and accompanying individuals. So it's not just the patient, it must also involve accompanying individual who have signs and symptoms of respiratory infection beginning at point of entry to the facility and continuing throughout the duration of the visit. Of course, in the era of COVID pandemic, this will involve everybody and not just to those patients with symptoms and signs of respiratory infection. Do take note on that. Post signs at entrances with instruction to patient with symptoms of respiratory infection to inform healthcare practitioner of the symptom when they first register for care. Cover their mouth and noses when coughing or sneezing. At present, as we are well aware, universal masking is indicated in this era of COVID-19 pandemic. Use and dispose of tissue. Perform hand hygiene after have been in contact with respiratory secretion. Dialysis centers should consider the following measure: provide tissue and no-touch receptacles for disposal of tissues. Provide resources for performing hand hygiene in or near waiting areas. offer masks to all patients, coughing patients, and other asymptomatic person upon entry to the facility if they have not done so, at the minimum during periods of increased respiratory infection activity in the community. And provide space and encourage person with symptoms of respiratory infection to sit as far away from other patients as possible. And during this pandemic, physical distancing should be adhered to, and staff should continuously advise patient and family to adhere to this. Adherence to physical distancing sometimes I notice can be very difficult to achieve. Constant reminder by staff needs to be carried out in many areas of dialysis centers. If available, facilities may wish to place this patient in a separate area while waiting for care. Okay, I'm going to move on to immunization and vaccination. We'll be short on this. This is the recommended vaccine for CKD patients. We are all very familiar with hepatitis B vaccine, so I'm not going to touch on this. However, the practice of immunizing our CKD patients, I'm not sure in other countries, but in Malaysia, definitely is very much lacking. With other vaccine are very much lacking. So I'm just going to show you this graph on the right is actually from a study that was conducted in the United Kingdom a few years back, which indicated that immunization with both pneumococcal and flu vaccine is associated with improved survival among dialysis patients. Flu should be given on an annual basis. Pneumococcal vaccine require 2 doses. One is Prevena and the other one is the Pneumovax. You can start off with Prevena. After 8 weeks, continue with Pneumovax, right? Most vaccine, pneumococcal vaccine that has been used in Malaysia are actually Pneumovax. Those patients who actually have gone to perform the Umrah and Hajj would definitely have received at least 1 dose of Pneumovax. COVID vaccine in Malaysia is now being deployed. At the moment, we are still in the first phase where the vaccination are for the frontliners. I think the implementation is not yet finished. As I understand it, the second phase for COVID vaccine, which is for person at high risk of mortality and morbidity, are going to be deployed in April. Dialysis population has been categorized as priority group to get this particular vaccine. I do strongly advise for you to counsel your patient to get this vaccination. In a quick survey that we perform, some center actually, many patients, I think about 10 to 15% of patients have concern about receiving COVID vaccination. So there is a role for us as healthcare practitioners to address their concern and to strongly encourage them to get the COVID vaccine. Yeah. Okay, I'm going to move on to staff education and competency. Okay, these are the areas or the modules for prevention of infection in dialysis that all staff must fulfill as part of and parcels of their day-to-day practice. First is on mode of infection transmission in healthcare facilities. The preventive measures to be undertaken, as I mentioned earlier. CVC care and CDC core intervention, as I alluded to earlier. Fistula care, environmental and equipment cleaning and disinfection, dialyzer reuse, water treatment management and its monitoring, and dialysis management is responsible to conduct yearly assessment and competency evaluation. In many hospital practices, environment and equipment cleaning is left to a third party. So I think the dialysis manager or dialysis management needs to intermittently checking whether the third party workers are actually comply to the policies and procedures of environmental and equipment cleaning and disinfection. Another poll, Profiling?
Yeah. When should staff training on infection prevention be conducted? This is multiple choice, so you can answer more than one. One is, you can answer more than one, remember that. Upon new hiring, to be repeated minimum on annual basis, when policies or procedure been changed. Yeah. The last one actually when procedures and policies have been updated and revised. Yeah. Okay, let us look at the answer. So yeah, actually the answers are all right. Yeah, upon new hiring and to be repeated minimum of annual basis, and when procedures and policies have been updated. Thank you.
Okay, so the answer is all. Okay. So on staff education and training, management of dialysis unit is responsible to provide job or task-specific infection prevention education and training to all the staff. These include those employed by outside agencies, as I mentioned earlier, and available by contract or on a volunteer basis to the facilities. Training should be provided upon hire, repeated annually, and when policies or procedures are updated or revised. All competency assessment must be documented. The staff must be educated on key recommendations for healthcare-associated infection surveillance and reporting. Dialysis unit must adhere to health authority requirement regarding HAI surveillance, for example, catheter-related bloodstream infection, reportable disease, and these include hepatitis B, C, HIV seroconversion, COVID-19, TB, flu, and dengue. Outbreak reporting such as pyrogenic reaction, and should you have a hepatitis C outbreak in your center. Staff should undergo training on clinical audits. Regular training on infection prevention practices must be conducted, and regular infection control meeting to provide feedback to all staff on infection occurrence, audit finding, as well as corrective and preventive actions needed to be implemented. Moving on to patients' education and family engagement. Or at minimum, all patients need to be educated on general hygiene, including hand hygiene, cough etiquette, understanding the dialysis process, what to expect and what may go wrong. The patient needs to be educated what they can do to protect themselves against infection. They need to be empowered to be able to remind staff to do the right thing. So the patient should be told if they see the staff that is about to touch them did not perform hand hygiene prior to touching them, they should be empowered to tell the staff, can you please clean your hands prior to touching me? Simple reminders if the patient is using catheter, if the catheter bandage gets dirty or wet, notify the staff. Ask staff they can use a fistula or graft for their dialysis treatment. Sometimes staff forget their fistula is maturing. And they must be aware of symptoms and signs of infection such as fever, chills, and rigors. As I mentioned earlier, many patients are very ill and very septic at the point of diagnosis as they disregard their symptoms of fever. And many patients retrospectively inform that they've been having fever during or after dialysis for weeks prior to presentation to hospitals. Other important points, care of dialysis access, patients need to be taught to check their dialysis access daily and to notify staff if they notice any signs of infection such as pain and swelling of their fistula site. Educate patients on the importance of vaccination. Patients should be educated on how they can avoid hospital admission. Remember that hospital admission, sometimes they ended up with another nosocomial infection, and definitely there have been multiple reports on nosocomial outbreak of COVID infection in the last couple of months. They should receive adequate iron and ESA. This can prevent anemias and prevent transfusion and risk of bloodborne viruses. The patient should try to avoid fluid overload and miss their dialysis treatment in this era of COVID pandemic to reduce their risk of hospital admission.
Another question.
Poll.
Okay.
Prof. Halim.
Have you treated COVID positive patient in your dialysis unit since the pandemic? Is that a yes or no?
It's good to know if anybody have the
experience
chance
of
to treat COVID positive patients?
in Malaysia, right, Dr. Rosna, our patient need to be admitted, right? Yeah.
Yeah. In Malaysia, our patients are admitted because they are basically considered high-risk group. There was a point when the incidence was very high that we were already discussing about contingency plan that we may not be able to admit all, and we were thinking about dialyzing category 1 and 2 in their own respective dialysis unit. But thank God, we didn't reach to that stage, and we managed to support all dialysis patients in public and private hospital in Malaysia.
It's about
So they are
50-50, yeah. But 42% actually had experience of treating COVID-19. That's interesting.
This is probably participants from other countries, I suspect. Yeah.
Yeah.
Or
hospital-based.
Hospital-based staff. Okay. And during this COVID pandemic, patient must be educated on steps to be undertaken to reduce their risk of acquiring COVID-19, because we know that CKD patients are at higher risk to acquire the infection in the first place, given that they can't stay at home. They still need to come 3 times a week to the dialysis unit, being exposed to another patient and even exposed to staff in dialysis unit. So they need to understand that, and they are among the most vulnerable group should they acquire the infection. Ministry of Health has produced this patient information sheet to assist patients to know the do and the don'ts. I'm not going to go through this. At least participants from Malaysia have probably seen this leaflet previously, but I am more willing to share these slides at the end of this presentation with participants from other country if this is helpful to you. Moving on to last section of this talk, what can we do to improve adherence in care deliveries? Okay, I've mentioned a few things about audit just now, but just to recap on what I've mentioned earlier, it is imperative that person in charge and the nephrologist in charge play a key role in developing and implementing infection control measure in the dialysis unit. Physicians' leadership is essential in preventing healthcare-associated infection. They need to be the role model in your respective dialysis unit, and they need to play a major role in developing and implementing infection control measures. So without a doubt, the involvement of the physician is important. And the PIC and the nephrologist, the PIC is the person in charge or the medical director of the unit, and the nephrologist should assist in the development and reviews, policies and procedures dealing with hand hygiene, vascular access care, personal protective equipment, medication preparation, water treatment and monitoring, disinfection of environmental surfaces and dialysis equipment, infection screening, immunization procedure, reuse practice, waste disposal, and they should ensure infection control is conducted regularly, and they are also responsible to ensure patient education and engagement are taken care of. The PIC, the medical director or the PIC and the nephrologist in charge should actively collaborate with the nurse manager to perform infection surveillance and audits of key infection control measures, and these include catheter-related bloodstream infection surveillance, fistula infection surveillance, and other infection-related admission, right? In a surveillance that I have performed in some of the dialysis centers, other infections related admission, including diabetic foot ulcers and pneumonias. Clinical audit to be performed at regular intervals include hand hygiene, PPE audit, CVC care audit, which include exit site care, connection audit, disconnection audit, and scrub the hub audit. Other audit which is relevant to infection control that you may want to think about implementing in your own dialysis unit if you haven't done so, fistula care audit, water logging audit, daily, monthly, weekly, medication preparation audit, reuse audit, as well as environmental cleaning and disinfection audit. And all the above needs to be discussed at regular infection control meeting And the data is discussed, the achievement is discussed, so improvement measures can be planned and undertaken. Okay, so this is my last slide, right? Infection control in dialysis unit is not the responsibility of the nurses alone. It is the responsibilities of all parties, the physicians, the nursing staff, the patients, the family. And these need to be led, the physicians need to lead by example. They need to be aware of infection control recommendation either by CDC or by their local health authority, wherever the guidance that you can get. They need to review all infection-related policy and procedure, perform or review infection control audit report regularly, discuss infection control during monthly quality assurance or clinical governance meeting, discuss with nursing staff area for improvement. And nursing staff needs to ensure and vigilant on practice of hand hygiene, aseptic technique, follow all infection control procedure, perform regular clinical audit, attend monthly infection control meeting with the physicians, the medical director or the nephrologist in charge, review all infection-related hospitalization and mortality, and why the patients get admitted should be discussed on a monthly meeting, and discuss with the physicians area that requires improvement. Patient and family needs to practice hand hygiene as taught by the staff, practice respiratory hygiene and cough etiquette, keep their catheter dry and clean, keep their fistula clean, wash fistula on arrival to the center, observe staff practices on infection control, and during the COVID, patient must wear mask at all times. And finally, in terms of facilities, staff nurse and the physician needs to ensure they are clean and contaminated areas available, and demarcation between the two has to be clearly delineated. Clean and disinfection of dialysis station and equipment in between patients, clean medication preparation area, and dialyzer reuse practice. With that, I thank you for your kind attention.
Thank you very much, Dr. Rosna, for very informative and complete lecture on infection and what to prevent the preventable. I think that's a really interesting topic and you have covered it nicely. We have a lot of questions and we will try to go through. The first question that came into that, is it possible when they are using glove, they actually use spirit to clean the glove in between procedures or in between patients? You know, they are wearing glove, they don't want to change the glove, they're using spirit to clean the glove.
I don't think this practice is recommended because you don't know what the alcohol can do to your glove. So the recommendation is basically to remove your glove, perform hand hygiene before you put on a new glove.
Okay, thank you. Then there's a question of do you need to use a full heat or chemical disinfect dialysis machine after every treatment in between patients?
Dialysis machine?
Yeah,
I think that's not our practice.
Yeah.
That's not really our practice. Are we talking about disinfection of dialysis machine, is it? No, that's definitely not our practice. Most of the centers actually do external disinfection of the dialysis surfaces.
Thank you. Okay. There's another question is that asking about, let's say, this is a bit difficult question. I think we go to the COVID questions. And first, okay, can I wipe the whole part of CVC using iodine? Again, the PVC. I think this is tubing, I guess. CVC. No, the CVC, they're going to wipe the whole part using iodine. So should be okay,
the whole part. That's not basically the usual practice. Usually what you need is to scrub the hub. That is where the potential source of infection It's actually,
Yeah.
if you introduce it into the catheter lumen, you don't really need to wash the entire
whole-
catheter with povidone iodine. Yeah.
Okay. Another interesting question. Can I mix alcohol and iodine before I cannulate?
Can you mix alcohol and iodine?
Before cannulate. So they don't want to use
Oh,
iodine or alcohol, they mix it, you know.
Oh, I'm not sure about that
Yeah,
practice.
sure.
I'm afraid I'm not
We
able
don't
to
use
answer
it.
that.
I'm not
Yeah,
sure
we
whether
don't
it
use
can.
it.
We don't use
Yeah.
it, you know.
I don't think.
There's
That's not definitely.
there's some questions about COVID. You know, how do you actually? Some of the questions are talking about disinfect machine. You know, but that's not the area of discussion, I guess. So how to disinfect the machine now? And some of okay. Okay, sorry. Okay, this is should we open window when we have a COVID-19 patient? Is it advisable? Let's say you have a COVID-19 patient, do you open the window for better ventilation for COVID-19 patient?
Window opening is definitely better than closed circuit, closed environment because of ventilation. Basically, I guess that's probably a better practice rather than keep the dialysis facility in a closed environment, right?
Yes, yeah.
But it's not easily achieved in some
That's
country.
true.
I guess country like Malaysia,
We
we are
are
very hot, and
air
it's not
conditioner.
easily
Yeah.
it's not easily practiced.
Just what is, because it's the for CRBSI rate, what we count if CVC patient admitted only treated IV antibiotic due to fever, but blood test and exit site didn't detect bacteria. Oh, this is something interesting, Dr. Rosna, talking about the definition of catheter-related bloodstream infection. So you said that some patient got admitted because of fever, assumed to have catheter-related bloodstream infection, but didn't grow anything. Do we count that as catheter-related bloodstream infection, or we don't take it as catheter-related bloodstream infection?
It depends. If you the definition of catheter-related bloodstream infection, you must have two criteria. One is the clinical criteria, such as fever during dialysis, generally feeling unwell, fever, chills, rigor during dialysis. So those fall under the clinical definition of CRBSI. The second definition is lab definition. Lab definition, and it must be an N, clinical and laboratory. So under lab definition, you must grow the same bacteria peripherally and centrally, right? And some for epidemiological purposes, there are even stricter definition where you must grow the same organism, right? For example, you must grow MRSA peripherally as well as centrally. But in most circumstances, we sometimes we cannot get that, and as long as we don't find any other source of infection, that patient, there's no pneumonia, there's no other skin infection, so on and so forth, we tend to manage this patient as catheter-related bloodstream infection. So it depends what you're talking about. Are you talking about epidemiological definition, or you're talking about clinical definition? Sometimes whenever we see a patient, it fulfills the clinical criteria, and you may not be able to get that lab criteria, definitely we still treat as such.
I totally agree with you, because sometimes they will send back to say this is a colonizer, you don't have to treat, but the patient came in with signs and symptoms of catheter-related bloodstream infection, classical, and we have to treat. If we do not treat, the patient will actually deteriorate. Totally agree with you. Another interesting question here to ask.
Sorry. I can understand where this question comes from about the CRBSI. Perhaps I think you want to address your CRBSI surveillance, but I think this is for you to decide your own definition, right? I personally would rather over reporting so that I can be very careful about that particular center, rather than under reporting and you're not doing anything to try and improve your infection. So it depends on you how you want to see this. I can understand you can probably have two set of data, whether you want to say this is confirmed CRBSI or suspected CRBSI for your own surveillance.
Yeah, I think it's a good idea. I have a very interesting question and put you on the hot seat, just to ask whether COVID-19 PCR needed before a patient enter a dialysis unit.
No.
Okay.
I don't think so.
Yeah.
I really don't think so. I think
yeah.
the best approach would still be triaging, meaning at the point of arrival, you ask the patient the same question, how you do healthcare assessment. Have you had fever? Have you had respiratory symptom? Have you been in contact with COVID-19 patient? I think those rules still apply. I don't think COVID-19 PCR is mandatory because the patient situations change every day. They might be negative today and they can be positive tomorrow.
Yeah. Well, one of the questions just now asked me, when you wash your hand too frequent, it become dry, and I think that is we cannot really escape that. Yeah.
But it is a problem with certain patients with a skin allergy. So you need to probably get a different type of glove because sometimes they are actually allergic to latex. And I guess for the staff, we normally advise them to use frequent hand moisturizers.
Yeah. Okay, we have so I'm really sorry because the questions coming in. Oh yeah, another interesting question to say that we want to reduce the rate of catheter. So in the center itself, how can we promote this? How can we increase the number of native fistula or graft, and reduce the number of catheter in your center?
I can answer for Malaysia. It can be very challenging situation for us because the healthcare system in Malaysia is probably slightly different than other countries. We have public hospital and we have private hospital. Most patients rely on public hospital because they're basically very cheap, whereas they have to pay a significant amount if they were to go and have their fistula created in a private hospital. So you can counsel the patients, explain to them. Some patients do agree to pay out of their pocket to have a fistula created in a private facility. And this is a challenging areas in terms of trying to reduce your catheter. But there are some patients who are completely deemed to fail their fistula creation because they don't have good vessels, so on and so forth. The options of PD should be discussed clearly, and if there are no contraindication for transplant, we should explore a potential kidney transplant from a living donors.
Another question is, does disinfect caps help to prevent catheter-related bloodstream infection, the caps?
I'm not aware of any studies looking at disinfection of caps, but definitely scrubbing the hub has been shown to reduce catheter-related bloodstream infection. I'm not aware of any studies about disinfecting the hub per se, the cap per se.
Yeah, there are so many questions that we have to choose. One of the questions asking about vaccine. I know we came up with the vaccine, but is in your opinion, Dr. Rosna, is there any dialysis patient that is contraindicated to get a vaccine? And if so, which type of vaccine?
I think all the available type of vaccine is now allowed for dialysis patients. Unfortunately, there is no data on efficacy and safety of COVID vaccination in dialysis population. I just looked through the literature yesterday to see if there is any data on hemodialysis. There's none, unfortunately. However, the studies is currently ongoing, and none of the vaccines are actually contraindicated. Not like for transplant. For transplant patients, some of the vaccines are not allowed, are not permitted for transplant patients. I hope I answered that question.
Yeah. What about COVID-19? Again, COVID positive patient, let's say dialysing in your center, can you reuse the dialyzer or you cannot reuse the dialyzer?
We tend to single use them because I think they are still concerned. I mean, there's still a lot of things unknown with COVID, but we generally do not reuse dialyzers for the COVID-19, worried about contact transmission, even though the data now suggests that contact transmission is probably less important than respiratory droplets, right?
Interesting. Do you recommend curtains in the dialysis center, dialysis facilities? Curtains in between patients?
It's probably not a good idea because you can get blood spill all the time, blood splash all the time. But in terms of patient privacy, you probably use one of the screen rather than a dialysis, rather than a curtain.
Yeah, I think we already
especially in the era of COVID, even the wards also, we don't put curtains nowadays.
Yeah. Thank you very much, Dr. Rosna. There are so many questions, but I'm sorry to all the participants. We can only select few questions. We are actually running out of time. I understand that the questions are really important. I guess maybe S Club can look at the way, maybe they can email the questions and we can answer, the questions. Again, that bring me to the last point. I would like to thank S Club Academy for making sure this webinar successful. I would like to say thank you to Dr. Rosnawati for making this talk. It's interesting. Infection is very interesting and very complete talk. And as of course, to our participants that spend their night, or evening at your place to listen to this webinar on infections. So please refer to your chat box for the link and passcode to generate the e-certificate. And for Malaysian doctors, please scan the QR code here on the MAA apps, not on MySejahtera app, on MAA app to obtain the 1 CPD point. With that, thank you very much, everybody. Please enjoy your day, and thank you for joining us.
Thank you. Thank you so much for listening.
Bye, everybody.
Bye.